I have a lot of people who say, oh, are you just advocating everybody should have cesarean sections? That's not natural. And no, that's not what I'm advocating at all. What I'm advocating is the absolute right of every woman to know the options for her, to individualize treatment for her. And for us as the clinicians or the caregivers, respect the choice she makes. So you've got to think long and hard about how old are you when you're having your first baby? How many babies would you like? If you want a really big family, you want 4 children, 6 children, then do you really want to have a cesarean section? Because once you've had 2 or 3 sections, you will almost certainly need cesarean sections every time. And that increases the risks of the section every time. It increases the damage to the other organs. It means sometimes the placenta gets stuck, which is a really dangerous thing. So there are pros and cons for both. Also, nobody will ever argue that the safest, most sensible way to have a baby is a straightforward, uncomplicated vaginal birth.
Yeah.
The problem is, how do we know that that is how we're going to end up? And it's really hard to expect a woman who's in the throes of labor to make at that point rational decisions. So these are actually decisions that we should try and make to an extent before going into labor.
Welcome to the 51%, the podcast where we cut through the noise and get back to basics when it comes to women's health. Through expert insights and powerful personal stories, we help you tune in to what really matters. Your body, your well-being, your life. No one-size-fits-all advice, just real conversations to help you understand your health on your own terms. But before we dive in, I have a quick favour to ask. Please hit subscribe and join the 51% community on our website. It's free and it helps us grow, reach more women and create events that really speak to the health and wealth challenges we all face. And finally, just so you know, everything shared on this podcast is for information only. It's not medical or financial advice, and always speak to a qualified expert for support. Sushma, welcome to the podcast. It's fantastic to have you on. I'm excited to have this conversation because when we first met, you really kind of enlightened me with some of the things that you said, and I was quite frankly a bit shocked with some of the things that you said when it comes to gynecology and gynecological issues with women. So could you introduce yourself and talk a bit about who you are and what you do? That would be great. Thank you so much.
Thank you for having me. I'm Sushma Srikrishna. I'm a consultant urogynaecologist. I work in the NHS in King's College Hospital, and when I'm not there, the slightly more salubrious setting down the road in the Shard. Also in Canary Wharf and Lister, so all as part of HCA. I've spent, I have to count here, I think now 30 years doing gynecology. I subspecialty trained in urogynecology because I thought that was the best use of my time, because for women who are forced to otherwise see a urologist and then a gynecologist, they often don't get the kind of joint-up care that our problems frequently require. And as time went on, I began to realize that sort of really tied in with the hormonal changes, may or may not have had anything to do with the fact that I was getting to a certain time in my life, and just realizing that it affects every aspect of your being. So I decided to get accredited in menopause care as well. So that's how I now practice, which is benign gynecology, urogyne, and menopause. And I'm delighted to be on the show. So thank you very much for having me.
No, thank you. Thank you so much. So just to kind of kick things off, can you explain the difference between gynecology and urogynecology? Because before I'd met you, I'd never really heard of urogynecology. And in what instance would you see either or?
So gynecology, if you're talking about definitions, is any disease or condition which affects the female reproductive organs. So in a way, I suppose urogynecology becomes a sort of a small subspecialist part, except there is, of course, the problems of the bladder, which traditionally were never thought to be included in gynecology. But for women, very often, as most women who are of a certain age, women who have recurrent infections or prolapse will realize, is very, very frequently tied up with gynecology. So many years ago, some stalwarts in gynecology fought very hard, and it is true that we stand on the shoulders of giants, to introduce in our Royal College a subspecialty training accreditation for urogynecology. It's the youngest of the subspecialties. And even today, it's such a small world that I will personally know every single urogynecologist, at least in the country and very frequently overseas as well. So urogynecology is a part of gynecology that focuses on problems that occur with the lower part of the urinary tract, so the bladder and the urethra, ending, of course, in the pelvic floor. And that's where it ties in with gynecology, because diseases or conditions of the pelvic floor will involve things like pelvic organ prolapse, urinary incontinence, recurrent infections, and they're often very closely interlinked. So that's a subtle difference, and yet sort of the joining up of these two conditions.
Yeah, no, that's great. Thank you. Thanks so much for clarifying that. So I know, obviously, the pelvic floor is of really big importance, especially, for women. And a lot of women have issues with that. So under what circumstances would they have issues, and when would you know that you've got an issue, and why would you need to get it sorted out fairly quickly?
I think genetically, women have a pelvic floor that is never going to be as strong as a man's pelvic floor. Now, I'm out there waving the flag for feminism as much as everybody else. But the very fact that we do something quite phenomenal, which is get a baby out of us, means that by default, our pelvic floor needs to have a large opening in it, which is the vagina, which means that this natural sheet of muscle that men have, we cannot. It is divided by another orifice. And this is why the pelvic floor is inherently weaker. Problems with the pelvic floor are often a conjunction of genetic factors and lifestyle factors. So, for example, the collagen that we're born with. Shreya, you and I are blessed with strong collagen. We will thank our skin and our hair for this. But at the same time, that codes, for example, for the chances that you and I are much more likely to get diabetes. So similarly, when you look at racial differences, Caucasian collagen is inherently slightly weaker, which gives them the disadvantage of developing problems with prolapse and incontinence, a particular form of incontinence called stress incontinence, a bit more sooner in their lives.
Okay.
Whereas Afro-Caribbean women are, in amongst all races, known to have the strongest collagen, which is why that the one person who'll probably look younger at her age, so we've all got pros and cons about this, but they are likely to form keloids, for example, if they have a cut on their skin, because keloids are exuberant collagen healing.
Yeah.
By the same logic, they're less likely to get prolapse and stress incontinence, but they are weirdly much more likely to get the overactive bladder. So these are the genetic differences. I mean, it's worth knowing, but at this point in time, that's academic because there's not much we can do, not in our lifetime. I don't even think in our children's lifetime, because we can't fix the collagen. And for heaven's sake, please don't be drinking collagen, because it's not fixing it either.
Yeah.
It's only fixing the wallets of those who market it, but not much else.
Yeah.
And certainly not for the pelvic floor, but that's that. Then the universal factors which affect all of us is aging. Much as we try and deny it, as age marches on, some risk factors go up. And with every decade, the risk for pelvic floor dysfunction doubles. Then, of course, there's the single most risky factor for our pelvic floor is childbirth. During childbirth, particularly instrumental childbirth, big babies, long labor, particularly forceps-related deliveries, these increase the risk of prolapse and incontinence exponentially. Just to give you a number, I'm not a big fan of throwing out numbers, but if you've had a forceps delivery, you're about 20 times more likely to need surgery for prolapse than, say, somebody who's had a ventouse delivery or a vacuum delivery. It's 6 times higher. So there are these risk factors. The more the children you have, the harder the labors, the bigger the babies, all of these factors go up. Then you go on to the elephant in the room that's now a very popular elephant in the room to discuss, which is menopause. Menopause affects many things. And even today, it's 2026, and we talk about flushes, sweats, brain fog. I call it the Davina McCall effect.
Yeah.
Because, thank God for celebrities to come out and talk about it, because we're all talking about it. But what people don't talk about as much is that the effect it has on the pelvic floor. So the risk of prolapse and incontinence goes up thereafter. So these are universal factors. Over and above that, there are lifestyle factors. So, for example, the bigger one is, the more weight one carries through our pelvic floor. So if you are moderately or morbidly obese, you're more likely to have problems simply because of the pressure transmission. Mm-hmm. Similarly, if you're day-to-day, if you stack shelves for a living, or if you're a professional weightlifter, these are things that will increase it. If you have a chronic cough or chronic constipation, that's the big quiet, silent killer, because women will discuss their chronic coughs. They're unlikely to discuss their constipation in detail, except maybe with me, but then I have different discussions on a daily basis. So these are the things. Then there's, of course, the big exercise thing. Now, exercise is very good for you. We all know that. But repetitive, high-impact exercise, if you are prone to have a weak pelvic floor, I'm afraid to say, is not going to be your friend. Trampolining, work of the devil. There's been genuine studies to say that professional trampolinists, these are elite young women who've never had babies, over 90% of them leak on a trampoline. So these are all sort of the repetitive bang, bang, bang.
Yeah.
It's going to make these things work. Now, we can do lots of things to mitigate some of these factors, but these are factors that affect most women. So it's always a combination of these two things.
Yeah. So, I mean, I guess one of the key things is if you leaking and a lot of women, they don't talk about that. These are the silent things that they don't talk about. They might say, oh, I've had a hot flush if they're going through menopause, but generally they won't say, oh, I've just leaked,
Absolutely.
So if you are leaking or feel some kind of pressure down there, what can be done about that? Because I guess if you're going through menopause, there might be alternative things that you do in comparison to if you're not of that age. But generally, what kind of things would you do to, stop?
So it's an interesting myth that these problems peak only during the menopause. They don't. But if you're talking about difficulties in talking about these things, and if you imagine you're a middle-aged woman, I mean, once we've had a couple of babies, most women I know will talk about anything. They'll say, oh, well, we've had babies, here, we're all a part of this big, group.
Yeah.
Younger women find it even harder. They somehow feel they must have done something wrong, because why are they leaking? And this sort of secrecy in which everything is shrouded is the worst thing, because everybody goes around their lives thinking this only happens to me. I can't possibly talk to somebody else who's 30, because then everybody will know. This is why if anybody ever attends any of my lectures on this, I always have the rudest slides that I can possibly have, because it's just the shock value, which I want people to laugh about it, to realize it's not taboo. There's lots of us who go through this. And I was frequently, as I'll say in the beginning of my lectures, if you can't take the piss out of incontinence, what the heck are you going to take the piss out of? Yeah. So I think the first thing is education, awareness, and awareness of the staggering number of women who put up with this. So the first thing I think is to not let yourself get to that point. Well, you can't stop it, but I suppose how do you mitigate getting to that point? And the single biggest thing you can do for yourself is pelvic floor rehab, pelvic floor physiotherapy. France get this absolutely spot on. They have antenatal physiotherapy. Every pregnant woman will go through antenatal physiotherapy. And here we struggle to get physiotherapists on a postnatal ward on the NHS. And I get it. We're stretched. There's resources, there's finite numbers, but somehow women seem to always be the last group to be considered when we're handing out the sweeties. So there is this bit that we are the silent majority. We are, I don't know, as good girls, we just told to put up with things and not make a fuss and not shout. But the first most important thing you can do is train your pelvic floor so you don't get there. So that's physiotherapy. The second thing is the awareness of exercise and how it is good for you, but perhaps what exercise is best for you. Perhaps train with somebody who can teach you core strength and pelvic floor strength, not just the high impact, high Roxy or whatever the current fashion seems to be to exercise. So that's something you can do. Knowing what your options are when you actually go into labor, to know that it is your right to discuss these options and to request for various forms of delivery, and know that there are pros and cons for each option. So that's another way. Now, say despite all of these things, you find yourself having a problem. You either feel, oh my goodness, why did I just leak? And that's just one kind of leakage. Of course, you could have urgency, which is sometimes even worse, because when you leak, when you cough, laugh, or sneeze, you rapidly learn that that's going to happen, and you learn to squeeze and kind of cross your legs and stop. But when you have urgency, that is this overwhelming desire that you need to pee, comes out of the blue just like that. And in its worst forms, before you get there, or even if the toilet is right in front of you, you're wetting yourself before you get there.
Okay.
That is called latchkey incontinence. I mean, women give me these stories that they've come home with the shopping, they've left the front door open, they've dropped the shopping, by the front door, and they're rushing to get to the loo before they're wetting their clothes.
Yeah.
So if any of this happens, seek help. Come and see somebody, because there's so many things we can do. You do not have to put up with it. It is most certainly not normal. And there's lots of very effective treatments.
Is it ever too late?
It is never too late.
Yeah.
Never is it too late. We can always do something to help you. And whilst in medicine, as in life, I suppose, there's never 0% or 100%, we can certainly aim towards the 100%, and you can be much more comfortable on a daily basis.
Yeah. So, with the pelvic floor, I feel like there's lots of different circumstances that you can get it. And it's not necessarily, if you haven't had children, you can still go through that. But if you have had children, I feel like there's more of a chance of you getting
Yes.
it. But what about if you've had a C-section?
It's a very good question, and a very controversial question that we discuss very frequently. On the one hand, like I just said categorically, if you've had a difficult delivery assisted by forceps, there is very strong evidence which comes from Scandinavian Norwegian data to say you're 20 times more likely to need surgery for your, it's not even just that you're likely to have the problem, you're 20 times more likely to have a surgical solution for your problem. So what is the, what's the option? And then immediately I have a lot of people who say, oh, are you just advocating everybody should have cesarean sections? That's not natural. And no, that's not what I'm advocating at all. What I'm advocating is the absolute right of every woman to know the options for her, to individualize treatment for her. And for us as the clinicians or the caregivers, respect the choice she makes. So for example, if you are short, so if you're under 5 foot tall, and you're making a big baby, which we can work out by your scans and examination, you're much more likely to have long, difficult labor to push. Ultimately, it's a passenger and a passage issue. So one has to be big enough to accommodate the other. The longer you spend in the second stage of labor, the more likely it is that, you will get into problems. So cesarean sections, I'm often asked, will they cure everything? And the short answer is, I'm afraid not. Because even during pregnancy, the very fact that you're carrying a human being in you with the additional weight for 9 months sets you up to have uncovering of these problems if they are there. So if somebody leaks during pregnancy, and it's not a one-off when they're having sort of leaking, I will often say to them, let's talk about delivery when you are nearly ready to have a baby. So in the 3rd trimester. Because if you're already leaking urine at that point, is there much that we will achieve by offering you an elective section? Apart from you will continue leaking, but you've also compromised to an extent your core strength by making a cut through your tummy. So that's a consideration. If on the other hand, you're not, but you're dry at this point, then to make a decision on whether you've got a really big baby, do you want to have a section? That's a different thing. The second thing is, of course, cesarean sections themselves are their operations. So we do them all the time, but it doesn't take it away from the fact that they are operative interventions. So you've got to think long and hard about how old are you when you're having your first baby? How many babies would you like? If you want a really big family, you want 4 children, 6 children, then do you really want to have a cesarean section? Because once you've had 2 or 3 sections, you will almost certainly need cesarean sections every time. And that increases the risks of the section every time. It increases the damage to the other organs. It means sometimes the placenta gets stuck, which is a really dangerous thing. So there are pros and cons for both. I made my own choice when I was having a baby, and I wanted everybody to respect that choice because I accepted there's no 0 and 100%, and I do the same for all my patients.
Yeah, absolutely. I think it's a personal choice, and everyone's body is different, and it should be taken for that fact only, and not what everyone else is doing, because otherwise what's the point?
Absolutely.
It becomes.
And also, nobody will ever argue that the safest, most sensible way to have a baby is a straightforward, uncomplicated vaginal birth.
Yeah.
The problem is, unless you've got a crystal ball, and gosh, I want that if you have it, how do we know that that is how we're going to end up?
Yeah.
What we don't want to do is defer these decisions, get into problems, and then you're saying, well, the end is almost in sight. I'm just going to try a little bit longer. And then the second stage of labor, which is after the womb, as the neck of the womb is open fully, but the baby hasn't, made its presence in the world. That's the second stage. If the longer and longer that is a problem. So that, again, the argument is to manage that second stage really well and give women the options. And it's really hard to expect a woman who's in the throes of labor to make at that point rational decisions. So these are actually decisions that we should try and make to an extent before going into labor.
Yeah. I guess, the key thing is to ask, if you're going in for a natural birth, what would happen if you ended up having a C-section?
Absolutely.
And how does that pan out? Because knowing that can really help a lot. I mean, I know mine was an emergency C-section. I had no idea what was going on. It was a decision that I just had to agree with, and my husband agreed with. I still had no idea what was going on. It was a very quick thing, and I felt powerless.
Yes.
I felt
that
completely
is the word.
Powerless. And that was the worst thing. For me, it wasn't about the C-section. It was about feeling powerless. And it was a horrible feeling.
Yeah, no, you have my absolute sympathy. Because we go up there and say if you go up to a woman and say, oh, you have 5 minutes to make this critical decision. Obviously, all moms are going to end up saying, I'll do whatever you want. It's best. And they'll sign anything that you give them at that point.
I didn't even know what I was signing at this point, to be honest.
I mean, there's lots of sort of discussion around, is there any meaning to that consent? I mean, what is consent if you're just going to scribble on a piece of paper? It's not meaning, it's not informed. How is it valid?
It isn't informed, actually, because at that point, like for me, it was an emergency. So I didn't have, many, minutes to even decide, right? But I think it is about having the power to understand what's going on.
Absolutely.
And that is the key thing. It's not about natural or C-section.
And also, even amongst natural delivery, if it's all very well to say that we're aiming for vaginal birth, what happens if you're chugging along nicely, everything is going well, and then you're fully dilated, you can see the head, but just in the distance, and then somehow things don't go so well.
Yeah.
At that point, what we're going to do, that is the single most difficult decision any one of us has to make in obstetrics. Obviously from the mom's point of view, but also from the clinician's point of view, because there is no right answer.
Yeah.
In fact, there's a very nice little paper called Your Choice, which is UR and then choice. And each of one of those letters is an acronym for your race, your height, the weight of the baby, etc., etc. Professor Freeman, who is an obstetrician from the Plymouth area, came up with this. It's not 100%, but it allows a woman to input her own data into this, sort of acronym and come up with what vaguely we hope is best fit. So it just takes into account how tall you are, your genetic predisposition based on race, baby's weight, your weight, all of these other factors, and tells you what is probably best fit for you. And then, we live our lives on best fit at all times.
Yeah. Oh, that's great. That's great. I'll take that information from you.
Absolutely.
And put it in the notes, definitely, because I think that's important. And like I said, it's about choice and having the power to know what's going on and making the right choice. So I want to move on to the kind of gynecological side of things now. There are lots of things that can go on with a woman's body in terms of gynecological issues. And I could ask you could you name the most common, I guess, and maybe a few uncommon ones that people wouldn't really think about or know of?
Common, I mean, given that I'm a urogynecologist, the commonest the three commonest things that I see as a urogynecologist are recurrent urinary tract infections, usually in two specific age groups, younger women and sort of perimenopausal, menopausal women, prolapse and incontinence. These are the commonest things urogynecologically. From the non-urogyne, general, keeping in mind I don't do any cancer work at all, I do only benign gynecology. Commonest things I will see are, in fact, bleeding disorders, and that covers a whole gamut of things. Bleeding disorders and fibroids are a part of this. Pelvic pain. And interestingly, more and more women are finally talking about, again, a massive elephant in the room, which is dyspareunia, which is the medical word for painful intercourse. So many women have painful intercourse to varying extents, some to the point where they cannot tolerate penetration at all. And these are often young women who then live their lives in either just kind of literally just bearing and putting up with it, or relationships breaking down and, living their lives in a lot of upset. And there are very many causes for this. But those I would say, whether it is pain, bleeding disorders, and a subsect of pain, which is dyspareunia.
So, I know a lot of women can go through that when they're going through their kind of perimenopausal, menopausal states as well, when it comes to pain, and then the dryness, and then the leaking, and then, there's so many other things. At what point, should you always go and get that checked out? Because the problem now, I feel, is that, a lot of things are just put down to perimenopause or menopause, and it must be this. But it might not be. What else could it be?
I'll slightly change that on its head and say, even if it is perimenopause or menopause, why should that be a full stop? That should surely be the beginning of the sentence that, okay, this may be related to the menopause, but it's still not normal. So why the heck am I just sitting here and putting up with it when there are so many things to do? And again, the reason is people just don't know, right? So yes, a lot of times when women go through the menopause, they have this subsect of menopausal symptoms. Usually these occur about 5 to 10 years down the line. It's the biggest elephant in the room. And now we call it the Genitourinary Syndrome of the Menopause. So that is broken down into two aspects. You have bladder problems and you have vaginal problems. Basically, what a lot of people don't know is the vagina, but also the bladder, are desperately dependent on estrogen to thrive. So as our estrogen levels begin to fall, these begin to get thinner and thinner, and they really dislike it, and they make their dislike loud and clear. So from the vaginal aspect, so women will come and say to me things like, I feel like I'm sitting on a cactus. Day and night, I just feel I'm sitting on a cactus and it's driving me, insane. Or I can't bear the touch of my underclothes. So I'm not letting my man come anywhere near me if I can't bear my knickers. So that's another thing people will say. They always feel they have discharge. They always feel they have thrush-like symptoms. People will have gone to every pharmacy and taken every kind of anti-thrush medication. But of course, it's not going to get better because it ain't thrush. Or antibiotics and so on and so forth. And it's not just the women. Some of the practitioners are not aware that this is related to the menopause. So they have antibiotics on the assumption there must be a vaginitis. There must be a bladder infection. So that's one side of things. Then the bladder, you have women who come in with recurrent cystitis-like symptoms. When I say cystitis-like, it just means you feel every symptom of, burning, stinging, going 300 times a day. But you go there and you pee in a pot and somebody dips it and says, nope, there's no infection. And you want to throttle them because you're saying, I feel it. What do you mean there isn't one? That just means it's not culture-proven infection, but your brain is interpreting those signals as UTI, that's urinary tract infection. This is because as we get further and further into the menopause, these tissues get thinner and thinner. And then everything is kind of on high alert and inflamed. So often for these women, vaginal estrogen is like life-saving, life-altering medication, and it is so simple to give. And unlike HRT, has zero risk associated with it. Now, I deal with a lot of women who have had breast cancer and are breast cancer survivors just on account of where I practice. And apart from a small minority of those women, even in women who have had estrogen-related breast cancer, we can still give them vaginal estrogens. And if we can't do that, we can still find other things to give them, which just calm things down. So often a combination of something as simple as a pessary every night for a few weeks and twice weekly thereafter, and something like a collagen moisturizer. This is what I tell all my women. Think of a collagen moisturizer like a really jolly good face cream, but for your bits.
Yeah.
So alternate that with a vaginal estrogen, and then you feel so much more comfortable. I mean, I don't want to think of my vagina all day.
Yeah.
It's just really annoying. I want to think of it when I want to think of it. I mean, it's ridiculous, isn't it?
Yeah.
It must drive you crazy if that
Yeah.
happens. So that's a very common thing.
If you do decide to take vaginal estrogen, is that something that you're on, is it for life? Or can you kind of come off it and things will be back to normal?
It is highly unlikely that they'll stay back to normal. You will have to use them long term. But if for whatever reason, because it genuinely has no side effects systemically, that's why you have to realize what vaginal estrogen does. It only works if you have hot flushes, and no matter how much vaginal estrogen you take, your hot flushes are going to stay.
Yeah.
That's the same reason why it has no side effects. It doesn't go into your bloodstream. It acts where you put it in the vagina. And because the bladder is right on top of the vagina, it helps the bladder. Because of this, the virtue of this is you can put a pessary, and then it is not going to change anything else, but it will give you a lot of relief from these symptoms. But by default, then you have to keep up with it. So it's twice weekly. It's not every day after a certain period of time. Twice weekly, put it in your calendar, brush your teeth, put your vaginal estrogen, go to bed, you wake up feeling, much better.
Yeah.
So yeah, often. And worst case situation, people don't want to take it. And I'll say, fine, come off it. Nothing sinister is going to happen. It's not like coming off your antihypertensives and keeling over with a stroke. You'll just begin to feel uncomfy again. If you do, it's time to go back on it.
Yeah. No, that's great to know, because I think people have this view of, some people don't really want to go down the HRT route, and then they think vaginal estrogen is a similar thing, so they don't want to use it for various reasons. But if they don't want to use anything related to hormones, what are the alternatives?
So, I mean, again, every woman has the absolute innate right to tell me, thank you, but I don't want to use this. Fabulous. Now, there are some women who really want to use it. And in that small subset, when we do our MDTs, which is multidisciplinary team meeting with the breast oncologist, I'm talking about breast cancer women here, a very small proportion of them who are on a specific kind of medication cannot have vaginal estrogen. But even for those women, there are other things we can do. So what are those? Firstly, we go back to the collagen moisturizer. That's your best friend. Put a good face cream, put a good vaginal cream, and you're happy. Both ends are happy.
Yeah.
So I often use Hyalofem, but not that I have any shares in it. But I find that it gives women good relief.
Hyalofem.
It's a moisturizer. You can buy it anywhere online.
Okay.
Or there's Replens. These are two kinds of things. There's moisturizers and lubricants, and they're different. Moisturizers you use on a regular basis. A lubricant only during intimacy. So the things I will say to women who don't want to or can't have estrogen vaginally, use a moisturizer, use a lubricant during intimacy as the easiest things. What else can we use? There are other medications. These are called selective estrogen receptor modulators. For example, the name of the medicine is ospemifene. It's a medication that works like estrogen in the vagina. But unlike estrogen, it's an oral tablet. You don't put it in the vagina, you swallow it. But when it gets absorbed, it acts in the vagina like estrogen, but it doesn't act on the breast. It doesn't act on the uterus. So if you have other endocrine hormone related problems, you can still have ospemifene. And of course, if you can't have that, if you're, they're not happy, there is the vaginal laser that is called Mona Lisa Touch. And there are many lasers, but the only one I will talk about is Mona Lisa Touch, because I think it's the only one with the sort of evidence that I need to see to feel comfortable to talk about it. This is a very interesting concept. It's an outpatient procedure that, it's like a clinic procedure. You come in and you go home.
Probably not on the NHS though, right?
No, it's not on the NHS. And actually, even if you have insurance, this is an important thing. I'm glad you brought that up. Most insurance companies at the moment are still not covering it. And I suspect that's because it's not covered in the NICE guidelines. in King's, we did a trial on it. Other people have done trials on it. So on the NHS, we're allowed to use it, but only in the research setting, at least for now.
Yeah.
One lives in hope that that will change, but for the time being. But what it does is it's a probe that goes in the vagina. It's a very fine probe. It's not painful. It doesn't need any anesthetic. And it heats the tissues very, very gently to a very specific temperature, which is not uncomfortable. But in doing so, studies have shown that that stimulates that cell, which was dormant, to begin to produce collagen, which is ultimately what they had stopped doing once they didn't have estrogen. So to achieve that effect, we would say that you should have the Mona Lisa treatment, at least 3 to 5 settings to start with, about 4 to 6 weeks apart. And once that is done, come for a top-up as and when you need it. Most men won't need that length of it. They'll probably need a top-up every 6 to 12 months. There isn't as robust the evidence that we should have that, will allow us to put it on the NICE guidelines yet. But there are equally no side effects. And for the women that I have seen it work in, it makes the difference between, getting really upset, getting really down, relationships getting really pushed to the brink, and, hope. So I use it. And in my patient population, I've seen reasonable results. I think that's another thing that we can try.
That's great to know, because I think people, a lot of women go in and think, HRT or estrogen, these are going to be my only options, and I don't want to do that. There's nothing else I can do, because they're not really given any other alternative options.
The other thing, it's not vaginal, which is unusual for me to talk about it then. Even for hot flushes, there's a non-hormonal medication. It's called Physiotherapy, and it's marketed, I think, as Vioza. This is an oral tablet, and it's specifically used, I use it quite a lot now. It's been around, it's approved by MHRA and everything for the last maybe 3 years, 4 years. And now it's available at most general practices as well. That is quite effective in the treatment of hot flushes. I mean, GPs have traditionally used other things. So they've used venlafaxine, paroxetine, gabapentin. These are useful medications, but this one is specifically been designed for hot flushes. And as long as you have some regular blood tests to make sure everything is okay, that has worked really well in a population of breast cancer patients. So there are always things that you can have. And I suppose the main thing is to not just give up, that they cannot possibly be anything that helps, and not talk about it. Because once we talk about things, somehow magically we come up with some solutions.
I guess it's, again, feeling empowered to kind of, if there's something you don't want to do, ask your GP or practitioner, what are my alternatives through, if NHS is your only options, through the NHS, and if you can go privately through insurance, or, just pay yourself, privately as well. Because if you don't ask those questions, then you're never going to know.
And once you have all the options, you decide what works for you, what's within your remit, which isn't, and at least then you make an informed choice. Absolutely.
So I also want to touch upon something you mentioned, which I had no idea about, to be honest. And when you mentioned it, I was actually taken aback. And this is going back to urogynaecology now. Okay, I'm flipping. So when with intercourse, you mentioned that, a lot of people, well, just generally when women are talking and men, it's this urgency, I need to go to the toilet. But can you expand on that? Because you mentioned that before you're about to have intercourse, you might have this urgency that, I better go to the toilet. But actually, that's not really something that...
So it's something that I tell every single woman who comes through the door, and they all look at me and say, And then they then look at my credentials and say, maybe she has a string of degrees. Maybe we'll try this. It's because when you talk about, first of all, we don't talk about sex. And I don't know why we don't talk about sex. We should be talking about sex. We're all having sex. So why don't we talk about it? And sex, when you think about it, is, as I often say, deeply unsexy because it involves two people. And the biggest problems women have are either infections or this sensation that, my friends always say go for a pee before. Not really sure even why, because otherwise they feel, it might trigger an infection, or you might suddenly, in the heat of the moment, say, excuse me, darling, I just need to go for a wee. But the problem with peeing just before intercourse is that intercourse, with apologies to all the men out there who think they will go on and on like sting for four hours, isn't going to usually take that long to allow your bladder to completely fill up.
Yeah.
Unless you're busting before you're going to, have sex, but then by all means go wee, otherwise it takes away from the mood. I would much rather that women peed immediately after sex, because that's the time that if you go and empty your bladder and it has a reasonable volume so you can have an effective pee, will get rid of any organism that you may have had or you may have acquired during the course of intercourse, right? If you've peed just before, you're highly unlikely, apart from those of us with sting, to have a bladder big enough that you can actually pee effectively, and you need a certain volume. So then you can't pee, and then the bugs that are there in the bladder have a chance to make things worse. So what I always say for all the golden rules, Sushma's golden rules around sex are, don't pee before sex. Please have a wash before sex, both you and your partner.
Oh, really?
Yeah, always. Because again, this is just logic. You have bugs.
Yeah.
That's why sex is so unsexy when you break it down. You have bugs, your partner has bugs.
Getting rid of the heat of the moment now.
I'll let each woman and man decide how to weave that into foreplay, but for heaven's sakes, have a wash, whichever way you do it. Have a wash. It doesn't have to be anything fancy. It just reduces the volume of bugs that you're going to deal with. If you're going to be dry, even a little bit dry, use a lubricant. Again, why? Because when you think about it, why is sex fun? Because there's friction, and that amount of friction, your brain reads as fun. If you're a little bit thinner, a little bit drier, it veers towards from the pleasure and the pain threshold being very close to each other. Now, the same friction that is fun in your brain also allows microabrasions to develop. And they don't hurt. They don't cause you any symptoms. But from bugs' point of view, it's like, woohoo, sunroof access into the bladder. So use a lube if you're even a little bit dry. Now, hopefully this is a PG show and I can say what I want to say next, which is, please don't have anal sex from the point of view of UTIs, because that is the single biggest risk factor for urinary tract infections. It is because obviously most of these bugs will find it easier to come from your bottom into your vagina and there into your bladder. And repeated anal intercourse dilates the anal sphincter, and that anal sphincter is meant to be slightly more tightly closed and allows bugs slightly more easily to go from one end to the other. And once you've had children and vaginal birth, the natural separation between the two, which is the perineum, often gets slightly compromised. So it's just sort of practical things. So those are the the immediate things that I will always say. So wash before, don't pee before, don't have anal sex, and pee immediately after. So those are the sort of the golden rules that I keep on talking about.
I don't think many people know that.
Anybody who's ever seen me for any reason.
Yeah, because when I first met you and you said, pee after sex, I was like, really?
Yeah.
Like, I thought you should do it before because in case,
Yeah.
But what about for women that do leak?
Yeah.
Then what?
So it depends on, again, why are they leaking? So there are two times that women are likely to leak during intercourse. One is at penetration and one is at orgasm, right? So if you're likely to leak at penetration, that tells me that you're likely to have stress incontinence. So that is a problem. It is highly unlikely that you leak only during penetration and no other time. Therefore, come and talk to us beforehand. Let's just get rid of that for you overall. It shouldn't be just an issue that you deal with when you're having sex. If you're leaking at orgasm, that is much more likely to be a result of an overactive bladder. And again, it's highly unlikely that you only ever leak at intercourse. There will be other times, and then we can fix that too. So if you're fixing it, there shouldn't be a reason. But of course, if you feel that this makes a difference between having a meaningful sex life versus not, then, just pee before. But otherwise, if you're prone to UTIs, follow the golden rules.
Yeah. Are there any alternatives to pelvic floor exercises? Because, some women I speak to, and including myself, okay, I forget, I can't be bothered, or it's not part of my, habit, routine, whatever, and it just becomes a side thing until, you leak and you think, oh, God, I've got to do that thing, and then you forget again. That whole cycle just continues.
But it's human nature, isn't it? You do something until it's a bother, and the minute it stops being a bother and becomes a new normal, you forget, and then it happens again. That is the problem with all physiotherapy.
Yeah.
So I always make a comparison to it, anything else being like a crutch. Does it help? Possibly, acutely. But if you get reliant on this crutch, then the reason you're using that crutch, which was to help, say, a broken foot, the muscles of that foot become weaker and weaker and weaker. And then bizarrely, the thing that was supposed to be tiding you over, you become more and more reliant on that. So that's the same thing with everything else apart from your innate ability to contract your pelvic floor. So this is why when anybody comes to see me, I bang on and on and on about, please see a physiotherapist. Then I get people saying, oh, I saw the physiotherapist. And I say, what did they do? And this depends on where they've seen the physio. Oh, they gave me an information leaflet. I'm like, are you sure? Because none of the physios who are genuine pelvic floor physiotherapists would just give you an information leaflet.
Yeah.
So as I often tell women, if you've seen a proper women's health physiotherapist, they will be examining you the way I examine you. Lying down, standing up, fingers in your vagina, feeling for what is happening when you contract. If they're not doing that, then that's not a proper assessment. So what happens when women are actually assessed and they're told to contract their pelvic floor muscles, they suddenly something twigs in your brain, okay, that's what I'm doing. So firstly, are you doing it properly? You may have done it 300 times a day, but if you didn't do it right in the first place, how do we know? So I often ask women to pull up or push down, and I will see that they're doing the opposite, or they're squeezing their buttock cheeks, or they're clenching their thighs. Everything apart from what I want them to do, which is squeeze their pelvic floor. And that's because it's hard. You ask somebody to flex their biceps and everybody will go that way, but it's hard because you can't see what you're doing. That is the difference between following a leaflet and actually going to see a physiotherapist. So I will often say, humor me. Go and see a physiotherapist that I'm recommending, just the once. And if you genuinely feel that it was the same as the leaflet, then, I'll eat my words. And this far, no words have been eaten. So everybody who sees a physio actually says, aha, that was a moment. Now, there will be some women, despite that, who cannot actually engage the pelvic floor. So for these women, the physios have special tricks. They have electric stimulation, biofeedback. These are little tricks that, you kind of see a needle move when you do the right thing, and it teaches your brain how to do it. Beyond that, I have fairly blunt views on vibrating chairs that you can go and sit on.
Yeah.
And again, as most people who come and see me, I will tell them, I'd rather go and buy a flash handbag. Now, that may be because I have a penchant for flash handbags, but at least that will last me a lifetime. The chair will work in a way for two reasons. One, your brain thinks you've paid so much money for it, so therefore this must be a good thing.
Yeah.
But also it temporarily stimulates your pelvic floor. But your pelvic floor doesn't know what to do almost in absence of that. So unless you have the disposable income and the disposable time that allows you to go and sit in said vibrating chair every week, then by all means go. But if not, the trick is, I'm afraid there's no other way about it. Learn how to contract your pelvic floor.
Yeah.
And we have lots of very able physios who will show you. There are squeezy apps. There are LV supporters. These are useful tips and tricks, but the physio will show you.
Yeah.
They will also show you how to link it with certain things. So, for example, you brush your teeth twice a day, most people. So you will learn to say, as I'm brushing my teeth, I'm going to do 10 rounds of, pelvic floor squeezes.
Yeah.
I'm driving or I'm about to get into the train and my commute takes X amount of time. I'll do one more. So if you associate it with everyday things, you will eventually learn how to do it. And mostly, of course, when you do it properly and you can see the benefit, you then begin to do it.
No, thanks for that. I think there's a lot of kind of misinformation, and then obviously there's, it comes down to laziness as well. I'm guilty of that myself.
Well, we all are.
So it's hard, and like you said, you can't see anything. So when you can't see it,
it's really hard.
It's hard, and you tend to forget more, I guess.
And I think we all live now, unfortunately, where everyone's gone to the university of Instagram and the university of TikTok and social media. Now, I'm not dissing social media. I think it's a very powerful tool and it's the quickest way to disseminate information. Unfortunately, it's also the quickest way to disseminate misinformation. And unless you have the ability to be able to sift through this, it's really difficult. I will get patients who will come to me and say after my whole consultation, oh, but I saw on Instagram that, so-and-so said so-and-so. And it's really hard to walk the line because I don't want to sound like a presumptuous so-and-so who says, oh, look at the string of my degrees, don't you know who I am, sort of a thing. But you really want to say, but look at somebody's credentials. Look at what is in it for them? If somebody on Instagram, and I, for example, for PCOS and things, there are some really useful Instagram sites, and I tell patients to read that because I know they're going to read it anyway. So it reads something sensible. Where people are not trying to sell you. If I say, oh, Shreya, come and do pelvic floor exercises, read my Instagram, is it called a blog? I don't even know what it's called because, I'm not social media friendly. And at the end of this, just click on this link, which will, spend X amount of money on this special supplement that I have designed. That only works to line my pocket.
Absolutely.
How else does it work for anybody? What's to stop people from doing that? So that's where, if someone's going to say something, they should have the evidence or the experience and the credentials. If you can find all three, follow them. Otherwise, I think just be a little bit more savvy.
Yeah, absolutely. There is a lot of misinformation, and then you do need to look at who is that person, and it take people, they don't want to spend that time to make sure that that person's credible. Do they have the degree? Are they a certified, qualified, whatever they're meant to be qualified in? And then if they're selling you something on the back of that, what's their motive?
Exactly. I mean, we all need to earn a living. So I would never say that, obviously, if you're going to go to a service, you're paying for it. But it should never be some weird hidden cost which says, I'm wonderful, but you can only access me after you've clicked this link, which takes you to another link. So there we go. So that's my little spiel. I can't help it but say. But I see this a lot, especially in my younger population of women who have recurrent infections because they're desperate. It's hideous to have infections, absolutely hideous. And to be told, have this, have that, and have the other with no evidence makes my blood boil.
Yeah, that's the thing. It's the evidence, and a lot of things aren't backed by evidence, and, it's hard. It's hard. So just quickly, I want to touch on periods, menstruation, because obviously women up to the point of menopause have periods, and then that there are a lot of issues that I've come across now that women are facing, and teens as well with their periods. At what point should it be of concern, through your menstrual cycle? Because I've heard having a painful period is a no-no. That shouldn't be happening at all. Then I've heard, no, it's fine to have a slightly painful period. I mean, I've heard all sorts. And then I've also heard of teenagers and women in their 20s, 30s being given the pill to, just kind of, I guess, I call it, masking the symptoms because they don't know what's going on. It's just, take the pill or take paracetamol to kind of get on with your day. So what are your...
So that's a very good question to which there isn't a simple answer. Because there are two things to realize. A certain amount of discomfort is not uncommon when anyone has a period. I think it's so long ago, it's a vague memory, she says. But yes, so the younger you are, when your periods are just starting out, they can be particularly all over the place and a bit irregular. Also, you are not used to this, right? Beyond this, the problem is it is entirely subjective unless it's so bad that somebody is actually keeling over and having to go to hospital, in which case it's always abnormal. Pain, flow, flooding, all of these are subjective. So again, I will always tell women of all ages, if you are in doubt that this cannot possibly be normal, please come and just get it checked out. So when we ovulate and then we have a bleed, what happens when you're bleeding is your uterus is contracting and it's releasing, that lining. Right? The more you bleed, the more the uterus is contracting, therefore it's more painful. The heavier the flow, the more chances are there are clots. And to get rid of the clots, the uterus has to contract even more strongly. So these are really bad period cramps. Now, if you have bad period cramps, but you can get about your day, you occasionally need to take a paracetamol or a hot water bottle, or by almost trying to just not fixate on it, but exercising, going to school, university, work, actually suffices to just push that to the background. Maybe that's okay. But if the pain is so incapacitating that you find that you're rolled up in a ball and unable to get on with your day, you live your month in dread of, oh my God, my period is going to come and it's going to take over my life. You're curled up and you're unable to go to work. That is clearly abnormal. If you're bleeding so heavily that you're becoming anemic, or every 5 minutes you're running, or not maybe 5 minutes, every hour you have to change a tampon, or you're using a tampon and a pad, and still you're soaking a sheet, that is clearly abnormal. Just because it happens in your family to a lot of people still doesn't mean it's normal. It's abnormal for all those people. Be the first to come and seek help. Pain that is so severe that it incapacitates you and you have to have time off repeatedly, I think is a big red flag, and you must come in. Now, talking about masking pain, what do we do when people come in with pain? I would say that you should always investigate pain that is severe enough to get somebody to your clinic, because they have taken time to come to you. You should never dismiss painful periods or heavy periods, and we should always look for underlying causes. Now, what could those be? They could be fibroids. It could be cysts. It could be endometriosis. Endometriosis won't cause heavy bleeding, but painful periods, painful sex. All of these things are relatively not easy, but you can find them if you know what you're looking for and you have the right tools. Now, the vast majority of young women will have nothing when we've examined them. So then what do we do? When in medicine we don't know the answer for something, we call it idiopathic or dysfunctional, because we don't want to say this is menstrual bleeding because of I don't know what the heck you're doing. And it's common and it happens. We still don't know. Anybody who thinks medicine has all the answers is delusional, because especially the doctors, because we don't. It's not magic. In those women, can we still give them symptom relief? Absolutely. And that is the role of non-hormonal treatment, but also hormones. If I give a young woman with crippling pain, for which I have ruled out endometriosis, fibroids, etc., the pill, and she is happy and she can go to school, go to uni, go to work, is that just masking or is that treatment? That's the fine line. But should I just be dishing out the pill and not looking for a progressive disease that is kind of carrying on under the guise of symptom control? That is where we're wrong. I shouldn't be missing endometriosis. I shouldn't miss a large fibroid. And even if you find them, sometimes you will actually treat them similarly with the same hormones. But we know and we can monitor and we know the situations where we must intervene. So that's the difference, I think.
I think, and that is, very good to know, because I think a lot of women and girls, they go and they're automatically given the pill, but there's no investigation.
That's wrong.
Which is kind of quite difficult, because you should always, my personal opinion, you should always investigate. It might be nothing, and it usually probably isn't anything.
That's fantastic.
But you should always try and find out what the cause is, and if there is no real cause, if there's no endometriosis, or this could be anything literally wrong with your body, right?
Then you make a choice. Then you make a choice to say, well, is this pain bad enough that I want to be on medication, or am I sufficiently relieved that I will say, this is natural for me, I'm not going to have treatment? I only mention this because, again, it must be social media. I blame everything on social media. I'm clearly, and my son calls me a fossil and a dinosaur. He says, you blame everything on social media. But there is a trend that has emerged amongst young women where they don't want to take hormones. This is relatively new, I would say, in the last year or so. Even if the hormone is likely to give them excellent symptom control, they choose to not take hormones. They're unable to explain to me exactly why, but there is some fear factor associated with it. So I have no idea if a very popular influencer has, put it out on a site somewhere. Or what are these perceived risks that are so horrific that you'd rather go through this pain? But ultimately, hey, if that's what you're deciding to do, fine. But it is still my job to make sure I'm not missing something, give you these options. And then if you'd rather have the pain and take painkillers and not the hormone, absolutely. That's your right.
Do you think sometimes, aside from, endometriosis and fibroids and things like that, do you think sometimes, what you eat can affect these things as well? Obviously, what you eat can't get rid of your endometriosis, but do you think what you put into your body, whether it's alcohol or, food, cigarette, whatever, can affect these symptoms?
That's a question to which, a hand on heart, I cannot give you a 100% answer. I'll give you what I think is that, yes, it must do. Because the more and more we're moving into a world where convenience foods are ultra processed, I find more and more at the same time, I've seen women come in with discomfort. Now, will it cause menstrual discomforts? Possibly not. But how do you know that discomfort is coming from the uterus? You're just coming to me in pain. It could be from your bowel. You can't identify necessarily where it's coming from.
Yeah.
And there has got to be some relationship between what goes in, whether it's ultra-processed food, whether it's the fact that the big food giants put hormones in various, meat, chicken, whatever, and you eat it. Is there a relationship? Possibly. Is that an area which is terribly under-researched? Absolutely. So I don't know. A lot of women will instinctively begin to cut gluten, lactose, etc. from their diet and begin to feel better in themselves. Does that mean we're now living in a world where these intolerances have suddenly gone up? And if so, why have they gone up?
Yeah.
That's an interesting question. It often, interestingly, happens to perimenopausal women as well. I mean, I'm clearly Indian. I've lived my whole life eating wheat, in chapatis. And I discovered in my 40s it wasn't suiting me. Who knows?
Yeah.
So it took me a lot of elimination before I was like, what? Can't be chapatis.
Yeah.
I've eaten them my whole life. But now I find if I've eliminated them on a regular basis, at least wheat, I do better.
Yeah.
So I don't know. I don't know whether it's the modern world and the stresses of the modern world, the fact that we perhaps don't sleep as well as we do. We have more blue light. We have more screen all the time. Something is affecting our circadian rhythm.
Yeah. Yeah. I think it's, personally, I think, yes, it could be. And there's no 100% proven fact that these are definitely the things. But I think there's no harm in making sure that you're eating well. And
100%.
There's no harm in that anyway. There's nothing,
Absolutely.
It's going to do you good regardless, right?
And one thing I will say about particularly the modern world, we're a bit more now aware of health and fitness and longevity. So I do find a lot of people will come and say, I've cut out, for example, excessive alcohol. Less and less people seem to smoke, which is only a wonderful thing. But, I see that even...
Hopefully they're not vaping. But yeah.
Yes. But there seems to be this, this acceptance that everything that is brand new may not be the best thing, like ultra-processed food, and sometimes going back to the kind of food we used to eat when we were growing up, because your gut is happy with what it ate as a child, may not be a bad thing. And even if it doesn't cure the problem at hand, it goes a long way in generally helping how you feel, I think.
Thank you. Sushma, thank you so much for all your amazing insights. We've covered a lot of ground here, so thank you so much.
It's my pleasure. I didn't even realize how time went by. We were just chatting. So thank you very much for having me. It's been a pleasure as well.
Thank you.